Hello everybody, it's Martin Kiernan here and welcome to this week's Infection Control Matters. This week we will continue our trip around the posters at ESCMID Global 2024. Hope you enjoy our selections.
Okay, we found another poster and Brace picked one that's actually been picked as one of the top rated posters, so very discerning of you.
Well, hang on, when I picked this one, they didn't have the ribbon on it.
No, okay. No, that's what I mean. That's, great minds. I wasn't inferring you were just jumping
sarcastic,
in. Okay, no.
Well, actually, I've already done a quick one on another wastewater related poster that I found. This one caught my eye because it's about VRE surveillance of hospital wastewater. And they were actually surveying wastewater before they had a VRE outbreak.
Or before they knew
they had a VRE outbreak. So they were doing that through the beginning, I think, of 2022. Long story short here, during that time, they had a VRE outbreak involving 21 patients. This is done in the Netherlands, study.
What sort of unit does it say?
Well, this was hospital wastewater as well.
Okay, and it didn't say like it was a haematology unit or something. Okay.
No, they didn't say where the outbreak was. I suspect it was in hospital-wide.
Yeah.
So they were doing this VRE surveillance of the wastewater. They picked up Van A, Van B genes in that wastewater. What they found was when this sort of cluster came about, they were identifying it in the wastewater. And in fact, they identified it in the wastewater before they picked up the VRE outbreak.
Yeah.
And then what they did was they typed all the VRE they found in the wastewater. They compared that to the isolates outbreaks using sequencing, and they found the similarities. So actually, what they found was there was high VRE concentrations in the wastewater, and that they felt that this wastewater and surveillance of wastewater could really help provide a useful tool to early outbreaks in the case of VRE. And that what they were finding in wastewater was genetically linked to the outbreak in the hospital.
It'd be interesting to know if you could actually subsample the wastewater to different units, and you pick up on a unit that they was about to have a problem.
Yeah.
And use it as a predictor, really, and then change your intervention. Because, VRE, in my experience, only picks off the weakest links. The people who are most susceptible to infection. Yeah. So often it's been transmitting around before people start to show infection. So this might be really very useful for that.
Good, well,
yeah. Lovely. Thank you. It's Martin Kiernan here, and I'm standing in front of a poster looking at assessing the Hawthorne effect in a hospital from Karachi. Mahmood and colleagues are the authors of the Aga Khan University Hospital. And basically, they've looked at putting secret shoppers in doing hand hygiene audits. And I'm chuckling because I know what we think it's going to show, and boy, does it show it. So secret shoppers looked at nearly 1,500 opportunities, whereas when it was more obvious that the infection prevention team were doing this, they looked at just over 2,000 opportunities. The area with the lowest compliance after touching the patient's surrounding was 12% for secret shoppers, but 92% when the infection prevention practitioner was there. And with highest after body fluid exposure, so this is where there's a risk to you yourself, it's still 41% with the secret shopper and 99% if there's an infection preventionist there. So it's just enormous differences, which is what we all suspect. So once again, I do value doing any form of obviously over surveillance. People spot when infection prevention teams are there. So unless you want to produce a result that says 98, 99%, which many people have to because that's what they've got to report to their board, you don't get anything accurate at all. Therefore, who's going to be convinced that you need a hand hygiene program in your hospital when you've got 98% compliance? It's pointless. Whereas if you went to your hospital board and say, actually it's 12% and at best 41%, then people are going to set up and say, this is not very good. The other point I would just want to make on this one is, before aseptic procedure, with a secret shopper there, it's 42%. With an infection preventionist there, it's 95%. So this obviously means the staff aren't convinced that they need to do it. So I really like this. It's simple. It tells us what we probably know, but hopefully it gives this organisation something that they could then go back and work with, because we have to be honest about this and say, what is it in a real world setting if we're going to try and interrupt transmission?
Hi everyone, this is Brett, and I'm standing at ESCMID at a poster undertaken or written by, or lead author anyway, is Jong Han Kim, and it's the impact of early infectious disease consultation for central line associated bloodstream infections, and it was undertaken, retrospective study undertaken in Korea. Really, the goal of this study was to see any difference in early or late infectious diseases review of people who had a central line in ICU. And they were divided up, the group was divided into two, those that had an early infectious disease consultation and those that did not. And they had a really interesting composite outcome. So it was looking at whether or not people had appropriate antibiotics within 72 hours and a catheter removal within 72 hours. That's a central line catheter removal within 72 hours. And the 72 hours was also the cutoff for that early consultation phase, or a late. And those who received an early infectious diseases consultation had significantly better outcomes for those composite outcomes of appropriate antibiotics and catheter removal. Interesting, just shows the value of having early infectious diseases input into patients with central lines and central line associated bloodstream infections in ICU.
So earlier I had a little chat about the Hawthorne effect, and the author, Dr. Mahmood's by the poster now, so I just going to have a chat with him. And you were just saying, when you get a new infection preventionist join the team, what happens?
Yeah, so it's really interesting. So as soon as a new infection preventionist joins, our hand hygiene compliance drops.
Yeah.
And
so they're effectively a secret shopper for a while.
Exactly. And then they recognize, and then all of a sudden, hand hygiene compliance improves all of a sudden. So it's
brilliant.
Yeah.
To me, I mean, I was quite surprised though about how low the compliance is after body fluid exposure, because traditionally people, that's a risk to me, therefore I'm much more likely to decontaminate my hands, but they're still not doing it. Have you any idea why people...
Yeah, I think it's because people often wear gloves, and after gloves they assume that they don't need to wear hand hygiene.
Okay.
In fact, using gloves as a proxy for hand hygiene is really common where I am.
Okay.
So they just wear a glove and not bother wash to the hand.
And that explains the aseptic procedure as well.
Yeah,
Then, doesn't it? Stick a glove on, I don't need to do it. Okay.
Exactly.
And yet they do it if there's an IP there, so that's interesting as well.
Well, no. So when there's an IP there, they'll just keep washing their hands regardless of what they're doing.
Okay.
and hope they'll pick up fine.
Okay. I mean, what have you done with this internally then? Have you managed to feed it back to managers or clinical staff?
We did. So exactly. So then we present this to each of the departments and let them know that this is what's happening.
Yeah.
But then we've got to be more sneaky with our secret shoppers and keep changing the type of people. So we sometimes get A-level students, sometimes nursing students, sometimes it's elderly volunteers coming in.
Yeah.
Otherwise, they sort of recognize that too.
Actually, an interesting thing would be to get a nurse from one part of the hospital to be a secret shopper in an area that she doesn't know, and then not only would she be the secret shopper, but she would actually see for herself, actually this isn't really good at all, but she might go back and talk to her friends.
Oh, that's a good idea. Yeah, that's a good idea.
So, without knowing each other, if you have a big enough organisation.
It is. It's a fairly big hospital, but I can see units having fights then.
Well, almost.
You tattletale on us.
Well, competitiveness sometimes works.
It does.
You go back and say, hey, Ward X, I've just been on, they're really terrible.
Yes.
But actually we are as well. You never know. It might work. Okay.
Thank you.
Thanks very much.
Thank you very much.
I've now moved on to another poster looking at semi-continuous disinfection of sinks with UVC in a haematology department. And this is from Maastricht in the Netherlands. And what they've got here is a setup that at the bottom of the sink trap area, there's a UVC bulb, which is continually disinfecting this. So they got a significant reduction in the low colony count compared with the control group, 4 times odds ratio. A small significant effect for the control group in itself, but no significant effect found for a decrease in the SBL positive sink drains in the intervention group. So even though the number of E. coli went down, there wasn't any clear effect for ESBLs, which I find really quite interesting. I have wondered about these. There's a picture of these poster in the podcast description. You can have a look at it. So there's a UVC bulb there in the sink trap. It's obviously not going to penetrate, I don't think, far enough up the pipework to be able to stop biofilm forming up there. So that's the issue with that. I did wonder if it might stop biofilm forming, but it only reaches as far as it can see. So What I would have been interested in is seeing, did it affect what you get from a splash from the sink? Because that's how we get transmission. It's what comes back out of the sink. But I haven't looked at that. But that may be something that somebody else might look at.
Oh, good everyone. I'm just standing in front of a poster called Urinary Tract Microbiome of Asymptomatic Individuals with Spinal Cord Injury. This one's got my interest because of some work we've got coming up looking at trying to prevent UTIs in people who undertake intermittent catheterization in the community and look to see whether we can reduce the incidence of urinary tract infections in that population group. And if people who are undertaking intermittent catheterization in the community have often suffered or have a spinal cord injury. So this study was looking at those who had asymptomatic so who are asymptomatic, and they were looking at the urinary tract microbiome. And they did a whole range of nanopore sequencing and urine cultures and a whole range of laboratory tests that I'm not really familiar with. But I was just interested in some of the results here. Quite a number of people had underlying cultures had underlying cultures positive to a range of different bacteria, but had no symptoms. The Enterobacteriaceae group was the predominant group, and followed by the chart here. There's a few for Staph aureus, probably Staph aureus is the next one, highest there. But I found this interesting. They sort of looked at inflammatory markers as well. They were elevated in those who had presence of a bacteria, but that was not a statistical association between that and microbiological load. I also say microbial load, I should say. The sort of conclusion here is that urinary tract microbiome of asymptomatic individuals with spinal cord injuries does range from low to high microbial load with known uropathogens. And it really makes us think about making sure that we have a refined diagnostic approach to UTIs in this population group. So that was a study that was undertaken in Switzerland. Ezra Valido was the author of that study. Nice work. Thanks.
Okay, it's Martin here. I'm going to ask you to pronounce your name because I'm going to struggle with it.
Yeah, of course, I'm Dutch. My name is Tera Habbe Jansen.
Okay.
And the poster I'm presenting here today is a typical Dutch problem where we have really livestock-dense areas in the Netherlands. A lot of pig farms, a lot of poultry farms, veal calves. And you can see that in the amount of livestock-associated MRSA that we find in hospitals. And the Dutch national guideline says that healthcare workers colonized with livestock-associated MRSA, or with MRSA in general, can't work in patient care. When you find them and you pick them up, they have to be decolonized, get a treatment before they can get back into patient care. But you can imagine that if you're a nurse or a doctor, you're living on a farm, being married to a farmer.
I was wondering what proportion. Do you have any idea what proportion of healthcare workers live and work in a farm or married to somebody?
Actually, it's not that bad because some of the hospitals in this really livestock-dense area changed their policy for this reason, because they had some cases of nurses living on a farm who didn't fit into the guideline regulations.
Okay.
And actually were told, just look out for another job. And in the current situation, you meet every nurse you can find, of course.
I mean, I've been reading papers from the Netherlands over the years showing there is a lot of transmission between animals and the people who look after them. But your work is actually looking at transmission onward in the hospital. So.
Yes, that's actually, and we already saw in the national surveillance database that transmission from livestock-associated MRSA from persons to persons is not that big. It's almost always the healthcare-associated, sometimes the community-associated MRSAs that cause outbreaks, and hardly ever the livestock-associated MRSAs. And those three hospitals took the risk of allowing those healthcare workers to work in care if they had a persistent source of reinfection. They were allowed to work on low-risk wards, not on the ICU or the hematology, but in low-risk
possibly a
wards.
step too far early.
That's right.
Yeah.
And they were followed for 2 years period. The first 3 months they were screened monthly, and at least 5 patients they took intensively care for were also screened, just to check for transmission. And this protocol took 2 years.
Okay.
After 3 months they were screened quarterly. Also patients were screened quarterly. And actually 3 hospitals participated, and it took 10 years to include 24 healthcare workers. So it isn't. It's not a really big problem, but on the other hand, those were actually about 24 people who were on the edge of losing their job.
Yes.
So that's on a personal level, it's a high impact problem.
Yeah.
We found that we could eradicate a lot of the participants because no persistent source was present. Some of them, to be honest, actually 16 of the included healthcare workers had a positive household member, and they either lived on a farm or had a relationship with someone who works on a farm. And only 6 of them were persistent carriers, and almost completed the 2-year protocol.
Probably they're being re-exposed all the time.
Yeah, that's right. They are re-exposed all the time, and they were screened positive all the time. We had quite a lot of intermittent carriers. We also know that from literature. And because a lot of the staff is pretty young, we also saw that people ending their relationship, moving to other parts. Then the persistent source disappears.
Life goes on. Yeah.
Life goes on, the persistent source disappears, and then you are able to eradicate them successfully. So in the end, we only had like 6 healthcare workers who were positive for the complete 2-year period.
Okay.
Around those 24 healthcare workers, we screened 671 patients. On the moment, the healthcare worker actually also screened positive.
Yeah.
So if the healthcare worker screened negative, only 1 negative is not a negative.
Yes,
so then
sure.
the patients were screened also. But if they were negative for more than 2 screening moments, then the patients weren't included in our results. But we screened 671 patients. They took intensively care of. And none of them were MRSA positive. Not only not livestock-associated MRSA positive, but not MRSA positive at all.
So I wonder, is that because these particular strains don't transmit that well? Or is it the healthcare workers know they have MRSA, therefore they are more diligent with their practice? They practice hand hygiene more.
I think that both are part of the mix. It's both part of the mix. They realize they are colonized, and I can imagine that makes
careful.
that makes them more careful.
It makes them feel that they need to do hand hygiene rather than...
That's right, and we know that standard precautions are rather effective in preventing transmission, not only of livestock-associated MRSA, but a lot of other multi-drug-resistant organisms. So, the fun part is that last November, the revised MRSA guideline for the Netherlands was published, and now there is an exception for livestock-associated MRSA, and the guideline allows them to work in patient care under some conditions of screening them for a while.
Yeah.
Although there is one worry, but I don't know if you see that in the UK, but we find clonal complex 39H strains nowadays that are PVL positive, that actually do spread very well, cause a lot of infection, and right now about 11% of the CC398 strains are PVL positive and not livestock associated. I think we also find them in Asia, and they seem to spread a little bit more worldwide. And we find them in the people dense area, in the city area, and not so much in the livestock dense area. So that's something to be cautious of. The guideline also states that if the strain is PVL positive, they're not allowed to work in patient care.
Okay. Right. Well, thank you very much. Very interesting.
Thank you.
So I'm strolling around the exhibition, and I've been buttonholed by Tom Riley and his colleagues, and Deirdre Coolins is here with a poster about C. diff contamination of Australian retail vegetables and households. So tell me about the poster.
Yeah, we did a study between Western Australia and Queensland where we visited people's households. We contacted people via actually a marketing company. We were looking for people who were purchasing potatoes with dirt on them because we know that that's a risk factor for C. diff. We know. Well, there's the specially dirty ones in the supermarket.
And organic.
Those ones we know have quite a high prevalence of C. diff contamination on them. So we went out to people's households, visited over 200 households between Queensland and WA, and we collected samples from their pantry area where they store their veggies and from their chopping boards and from the potatoes themselves and cultured them. And we also did a simultaneous survey of retail outlets selling vegetables as well.
Could you describe the sampling method, just as a matter of
Yeah, so we used poly wipes. These are like moist sponge, and like you just wipe that over the surface and then you can put it through a stomacher to get all the spores off them and put them into a
I love stomacher. I think that's such a great
I know,
device.
It's a fun machine.
Yeah.
For the retail vegetables, we just peeled those ourselves using a sterile method, and we just cultured the peels directly into broths as well. And we found really high prevalence on the retail vegetables. 28% of potatoes were contaminated with C. diff spores and 33% of onions. Within the households, we found a low prevalence, but we are still finding C. diff in people's homes, which is quite interesting. So we found 6% of pantries and fridges were contaminated with spores. We got a lower prevalence of C. diff from potatoes, but we did use that different method with the sponge.
Were these people you knew had bought the vegetables, or were they just a random selection of households?
They were a random selection identified by this marketing company that we employed.
Had you any idea how long previously they'd had these vegetables in the house?
Yeah, so when they were contacted, we just said, have you bought potatoes in the past 2 or 3 weeks? I can't remember the exact time frame. If they replied yes, then we would ask, can we come to visit your home? And then that was all set up. But they were regular purchases of them, so they all made sure that they had bought them recently when they went in.
Because it would actually be interesting to know if people who hadn't bought any potatoes for about 6 months. I mean, it wouldn't work in Ireland because it would be happening you bought potatoes in the last 2 hours, which is slightly different.
That's true.
But, if you haven't had potatoes, how long would your kitchen remain contaminated?
But I'm sure that, there's probably spores coming in from other root veggies as well. Just be specific to the potatoes. They're just the dirtiest veggies you can buy. But we found them on beetroots, onions, carrots, lots of other veggies as well. So we just honed in on potatoes since we have the highest prevalence.
Conclusions?
Conclusions, yes, you have C. diff in your home. We probably should be getting messaging out to people when they get antibiotic prescriptions. Maybe you start cleaning your home a little more thoroughly with bleach while you're at that high risk, especially if you're in a high risk group, someone with IBD or cystic fibrosis or, elderly person, cancer patients.
Because they get advice about soft cheeses, but not about soft vegetables.
Not about cleaning their home a little more thoroughly, cleaning their bathroom, using other things. So we think we can look into this a bit more and look at. It would be lovely to do some epi studies to get that risk of using soup in your house as well. That would be nice. We're going to feed all of this into a model that's called system dynamics modeling, where we're actually going to kind of map out the whole One Health picture of C. diff and how it might be transmitting both in communities, hospitals, and testing different interventions that you could introduce to, with farming methods or community or DB practices if possible, to see if you can block some of those transmission pathways. So that's good.
Not using pig slurry on your vegetables.
Or human biosolids.
So the circle completes.
Yes, just amplifying C. diff all the time. That's practice.
Okay. Thanks very much.
Thank you.
Thank you. So I've found an interesting poster on prolonging the use of breathing systems using anesthesia for up to 7 days instead of 24 hours. And Cynthia, you're the prime author of this. Do you want to talk to me about the study?
Yeah, sure.
Should say where you're from. You're Erasmus, aren't you?
Yes,
Netherlands.
I am from Erasmus in the Netherlands, so working together with Julian Severin and also work in the group of Margreet Vos. What we did for our infection prevention together with our green team is that we looked at the possibility of extending our breathing systems in the OR for up to 7 days. And actually what we wanted to know is, does the exterior get contaminated along the days, because you cannot really clean or disinfect it.
So we're talking about anesthetic tubing here, basically.
Yes, breathing systems in the OR.
Yeah.
And what we did is we selected 4 ORs at our hospital where the systems would stay for up to 7 days. Exceptions would be either wear and tear of the breathing system, or if an isolation patient was treated. And what we actually saw is, after sampling them every single day on 3 different locations, that there wasn't any increase in contamination compared to the systems that were replaced daily.
Presumably there's filters on both ends of these, are there?
Yes, so we really looked at the contamination on the exterior part and not the interior. Because the manufacturer's instructions do say that you can use them up to 7 days, but that really is based upon an interior system, and not really the exterior part of it. So yeah, what we saw is, so in the daily cultures, 27% is positive with anything. A lot of CNS was found actually, and no pathogenic bacteria really, at least not on consecutive cultures. And in reality, or in practice, we see that very often the systems don't even reach the 7 days because they need to be replaced prematurely. So they also don't get the chance actually to get the contamination upon the days.
But you think it would be safe to use them up for 7 days?
Yeah. At least from our data, we do not have any indication that there's really accumulation of pathogenic microorganisms, and the things we do find are non-pathogenic.
So do you put in a cleaning system for them to wipe these over, or decontaminate them once a day, or something like that between patients?
No, we don't have any cleaning between patients. We do have strict rules on if there is any visual contamination, then they are replaced.
Sure.
Yeah.
Okay. And savings-wise, what do you think you could save?
So we can possibly reduce up to 70% of the breathing systems that are used.
That's plastic, isn't it?
A lot of plastic and cost. So if you look at the annual figures of what we might save, it's up to 80,000 euros possibly, but also the plastic, more than 3,000 kilos of plastics, and of course with that comes the environmental impacts of CO2.
Thanks very much.
Thank you.
Well, that's it from ESCMID 2024. We've thoroughly enjoyed our time here. Posters were excellent. I hope you've enjoyed our outputs as well. Thanks very much for joining us, and we'll catch you again on the next episode.